So very warm good morning, everybody. I am Dr. Prateek Bam. The topic of my today's presentation is all ceramics, laminates, Maryland bridges, and gingival retraction. Since it's a big topic, I'll run through the topics very briefly, but I hope you get the crux out of my presentation. Before starting, I would like to thank Team Cynodent for this opportunity. So the contents of the dental ceramic will be the dental ceramics, its general properties, reasons for the ceramic failures, the classification, the strengthening of the dental ceramics, and conclusion. So what is a dental ceramic? It is basically a Sanskrit word which means the burnt earth. Ceramos is the word from which the word ceramic is derived. It is compound of one or more metals with non-metallic element. Usually it is oxygen, boron, or silicon, and that will be used as a single structural component or as one of the several layers that are used in the fabrication of ceramic-based processes. So this is basically a definition, a bookish definition from Glossary of Prosthodontic Terms. Also, porcelain means a ceramic material formed of infusible elements joined by lower fusing materials. So most of the dental porcelains are glasses that are used in fabrication of teeth, for dentures, for pontics, and facing crowns, inlays, onlays, and other restorations. So it is one of the four major classes of the dental materials that are used for reconstruction of damaged, decayed, or missing teeth. And as I said, ceramos, or K is pronounced as C. So ceramos is the word which means the burnt stuff. So according to American Ceramic Society, they describe ceramic as inorganic, non-metallic, and typically crystalline material. And it is basically the compound which are formed between the metallic and the semi-metallic, metallic or semi-metallic, and non-metallic elements. Metallic elements include aluminum, boron, calcium, lithium, etc. While non-metallic, oxygen is one of the major components. So what is glass? Glass is a state of matter where the atoms and the molecules are randomly arranged. It has an amorphous microstructure, whereas the ceramic materials are composed of the crystalline structures in islands that are spread inside a glass matrix. Right. So the dental ceramics are composed of glassy or amorphous phase, or crystalline or lucite phase. So glassy matrix has translucency, it has surface tension, and it has the properties like brittleness and the crack propagation. While as the crystalline phase of the ceramic has the properties of thermal expansion, it has the strength, and it can interrupt the crack propagation inside the structure. So crystalline phase, it includes feldspar, quartz, and alumina. The feldspar is made up of the potassium aluminum silicate or the sodium aluminum silicate. Quartz includes the silica as a non-crystalline structure, and it helps in formation of bonds with the oxygen radical. The stability and the strength and the structure of the crystalline phase is formed by the quartz. Alumina helps in lucite formation. It fuses with the natural feldspar to form the lucite crystals. There's glass matrix has kaolin, the pigments and the fillers. So kaolin is basically hydrated aluminum silicate. It makes the mix, the glassy mix and the other mix as a workable mass. So during firing, it adheres to the quartz, and the fillers and the glass modifiers, they act as flux. And pigments are basically the colors that are imparted to the restoration. So according to the pigment, the pigment, the color is imparted. So iron oxide imparts yellow color, the copper oxide imparts a blue hue, the titanium oxides imparts white color, and the chromium oxide imparts the green color. So feldspar is an hydrous potassium and sodium aluminum silicate, as I said before. On firing, these particles fuse to become a glassy matrix and leads to the formation of lucite crystals and glassy matrix. So precipitation of lucite crystals leads to the change of ceramic properties, increased strength and hardness, but it decreases the aesthetics. So this is basically what the chemical reaction of the ceramics is. So feldspar is converted into the crystalline form and it gives silica. So glassy matrix is formed from silica, alumina, potassium, and crystalline or lucite phase is formed during the firing of the ceramic. And these are the crystals of potassium aluminum silicate. So coming down to the classification of ceramics, dental ceramics are classified into glassy matrix ceramics, polycrystalline ceramics, and the resin matrix ceramics. Glass matrix again has feldspathic ceramics, the synthetic ceramics, and the glass infiltrated ceramics. So glass matrix ceramics are basically inorganic. They contain no metals. They have a glassy phase, which means they are formed out of silica, and they can be naturally occurring, or some glass infiltrated particles can be incorporated into them. Feldspar is a synthetic lucite based material, and again glass infiltrated ceramic, aluminum. Synthetic ceramic, they have more crystalline phase to reduce the crack formation, and the crystals that are created artificially by controlled nucleation and crystallization. So examples of these are the lithium disilicate, the zirconia reinforced ceramics, and the fluoroapatite based ceramics. Coming down to glass infiltrated ceramics, a second firing with the lanthanum glass is done to increase the strength of the ceramic. The ceramic particles are sintered onto a die, and a ceramic block is made to produce via milling. So basically, these are the disc of the ceramics, and those are milled to form the restorations. So the form block is again fired along with the glass to increase the strength. So polycrystalline ceramics include alumina, stabilized zirconia, zirconia toughened alumina, and alumina toughened zirconia. So polycrystalline ceramics has the absence of this glassy phase. They are densely arranged crystals into regular arrays. I'll show you the figure in the coming slides. They decreases the crack propagation, and they have high strength and toughness, and they are difficult to etch. Resin matrix ceramics, they are also known as the hybrid ceramics. They consist organic matrix filled with ceramic particles, and they were included in the classification by ADA. Also, the ADA describes it as pressed, fired, polished, or milled materials containing inorganic refractory compounds. So these are basically formed for the computer-aided design and computer-aided manufacturing. So this is another classification based on the fusing temperature of the ceramics. So ultra-low fusing, which is less than 850 degrees Celsius. Low fusing ranges somewhere between 850 to 1000 degrees Celsius. Medium fusing ceramics, 1000 to 1300 degrees Celsius, and high fusing anywhere between greater to 1300 degrees centigrades. So classification based on the processing technique, conventional technique, pressable or lost wax technique, which is widely used, and machined or CAD/CAM technology. So in conventional, it is mainly used for veneering, and in pressable techniques, like we fabricate our PFM crowns as a lost wax technique. Basically, it requires a formation of a wax pattern, but it has more manual errors. And machine ceramics, those are basically the disc out of which the restorations are milled out, and it has better aesthetics, and it has more strength. So ceramics fail because of the following reasons. So it is basically the scratches or slits or roughness or facets that we can see on the ceramic surface. So if voids or bubbles get incorporated into the ceramics, if it has like during the processing of the ceramics. Also, ceramics do fractures. There's called as a Griffith's theory, where the crack propagates internally. So though the restorations are intact, the crack might propagate inside the ceramic itself, and the failure fatigue of the ceramics. So coming down to strengthening of the dental ceramics. Strength of dental ceramics is because of the stress concentration, the residual compressive strength, and crack propagation. Yeah. So metal substructure and the coefficient of thermal expansion. So basically, if the edges in the ceramic crack, there's a compression which creates a ceramic tension. And if the compression is inside the ceramic, like it is in the core, so tension is diverted outside. So if the tension is inside the core, so cracks do propagate, and if it crosses its modulus, the ceramics do fracture. So chemical strengthening of or the ion exchange of small glass monovalent ions with the larger ones. It increases the temperature. Large ions enter the glass matrix via the diffusion of from a molten salt bath. During cooling, these ions get lost and trapped and takes more space due to the higher volume, which leaves a superficial layer over the ceramics in a compressed state. So the ceramic is placed in the bath of the molten potassium nitrate. Potassium ions in the bath exchange for few sodium ions in the matrix. So thermal strengthening of the ceramics can be done. The stress profile reaches the deeper layer. During sintering, the outer layer solidifies first and it cools rapidly, which forms a solid layer over the ceramics. Whereas the inner layer cools down very slowly and it is still in the molten state. So this induces the compressive stress in the outer layer. So this method of firing can be subsequently used to increase the strength of the ceramic. Dispersion strengthening, addition of the fillers and its dispersion in the glass matrix can again strengthen the ceramic. The crystalline phase stops and the crack propagation has its more strength and higher rigidity. Increase in the crystalline structure therefore will increase the strength of the material. The dispersion of alumina particles increases the elastic modulus. The zirconium dioxide dispersed strength cores increases the transformation and toughening of the ceramic, using the lucite dispersion to increase the control crystallization. So transformation toughening, it can be seen in zirconium oxide or zirconia. The transformation of zirconia for a monoclinic phase to a tetragonal phase and back to monoclinic. So like when the crack propagates, it propagates and again the monoclinic phase is changed to tetragonal phase and the tetragonal phase again changes back to the monoclinic phase. So these transformation helps the zirconium dioxide to increase the strength and the toughness of the ceramic. So monoclinic phase when treated with 170 like 1170 degrees Celsius, it changes to tetragonal phase and again into cubic phase, and when cooled down the volume decreases and hence the monoclinic phase is again formed. So this is basically the tetragonal phase of the zirconium dioxide converts into monoclinic form and the crack propagation is stopped then and there only. So this transformation, like where the crack propagates, the zirconium oxide increases its strength because the monoclinic phase is again converted. So factors that are in the hand of clinicians to reduce the failures of the ceramic is the tooth reduction, the margins of the restoration, the metal coping, and the span of the restoration. So margin angles, as we always know, we should avoid the knife edge margins in any preparation. Chamfer and shoulder margins are preferred. There should be no line angles and point angles, sharp edges. So all the transition and the line angles are to be rounded to avoid the stress one. So if there's say a point or the edges are sharp, there will be stress concentration at where it changes the angle. So if it is rounded off, you can have more material to increase the strength. So multiple crowns can be given. The connector height has to be at least 4 mm. So in posterior, this may not be possible, but we have to make sure that the minimum cross section area should be at least 12 to 16 square meters. The deflection of FPD is directly proportional to 8 times that the length of the FPD. So anything beyond 3 units will be a long span bridge, and its deflection will be 8 times with the length of the FPD. And again, impression making should be very appropriate. Incorrect registration may lead to occlusal premature contacts and again stress concentration at that particular area. So coping should be designed in such a way that the compressive stress is maintained in the overlying ceramic. Thin porcelain uniform layer that is supported by the metal is the strongest. The desirable thickness of the porcelain is 1 to 1.5 mm. So any ceramic restoration, you have to have at least 1 to 1.5 mm of thickness. So be it your metal. So metal again should be, if we talk about porcelain fused to metal crowns, so they should be at least like 0.7 to 1 mm of metal should be there, and 1 to 1.5 mm should be your ceramic layering. So porcelain metal junction should be 1 mm above from the occlusal contacts, and it improves the stress distribution. So as you can see in the figure, if the static fracture is there, the porcelain remains intact. But if the fracture is in dynamic movement, the ceramic chips off. So with this, we conclude the first part of my presentation. So there are many clinical aspects that are important for the success of all ceramic materials. So dental materials in itself is a very vast science. You should understand the type of the restoration, the clinical case scenarios, and what material will be the best for particular case or for the particular patient. So you have to balance somewhere between your aesthetics and the strength that is required for that restoration to survive. And to optimize the performance of metal ceramic restorations, we need to understand the particular reasoning or why XYZ material is required for so and so case. So accordingly, we can decide our materials to enhance the longevity of the uh, restoration. So our next topic is the laminates. So as we all know, Charles Pincus is the man who pioneered laminates, and it was basically to enhance the aesthetics of the person who does dramatics, for the actors who wanted to change their appearance for particular roles. So laminates developed from there in early 1800. So Charles Pincus first gave porcelain facings with dentures, and in 1995, Bunocore developed the acid etch technique. And with the advancement, we had porcelain laminate veneers in 1983. So basic chemistry, the laminate is basically an internally etched porcelain veneer, and acid etch enamel surface is required, a silent coupling agent is required, and a composite resin luting cement, a dual cure resin luting cement is required. So advantages of using the veneer, to employ veneer as a treatment modality, is its excellent aesthetics. It has natural shade and stable color, resistance to wear and abrasion. It has resistance to stain because it is all glazed. It is resistant to solvents that you eat or drink anything, they won't get stained or get dissolved. Its resistance to absorption of oral fluids, and it has surface luster and retention. So again, long-term durability, marginal integrity, inherent porcelain strength. It is very high in strength, and because its thickness is minimal and the biocompatible nature of the material, it has soft tissue compatibility, and because they are very thin, somewhere ranging between zero point 0.3 to zero point 0.7, minimal tooth preparation is required, and it has lack of radio opacity. Disadvantages is basically the time and the cost that is required for laminates to fabricate. It is technique sensitive. It's fragile unless you know the proper bonding protocols and everything. And it is difficult to shade match, because if you're doing, say, a particular laminate or a veneer inside a patient's mouth with only one tooth, to match the shade along with all the other teeth, so you have to consider the shade selection, the color of the luting cement that has to be used, and it's irreversible. Once you have prepared the truth, you have prepared, and its inability to trial cement the restoration, because like full crowns you can temporarily lute and send the patient back, but for this you cannot do it. It is once and for all. Where do we use the veneers and the laminates? Extreme discoloration patients, patients who have undergone trauma in their childhood, teeth that show the amalgam shine through, any surface defect, to change the shape of the tooth, replace the fractured parts of the tooth, closing the spaces between the tooth, short teeth, malocclusion, peg-shaped laterals. There's wear of the teeth. Also, a functionally sound PFM or all ceramic crowns with a unsatisfactory color. So you can put veneers on laminates on those parts too. So contraindications, bruxism patients should not be given the options of treating the teeth with the laminates. Short teeth, because you don't have much of the prosthetic space, and teeth with inadequate enamel, because bonding, enamel is like the most important thing. Also, severe abrasion cases, endodontically treated teeth with large restorations, because if the strength is not there, you have to give a full crown. Also, oral habits of the patient, class 3 patients where you have edge-to-edge bites and overlapping bites, end-to-end bites, and deciduous teeth and excessively fluoridated teeth also cannot go for laminates. So how do you fabricate laminates? Basically, diagnostic aids and planning aids should be properly used. So before planning any case, we should give a wax simulation to the patient. So how exactly your teeth will look if you say there are basically two things. One is the additive and one is the subtractive. So while waxing up the patient for a particular case, it is an additive thing. So it is called as an additive mock-up, right? So you wax up the patient and show the patient that this is how your teeth will grossly look once you have done the treatment. So if the conventional methods are not enough, you can go for computer imaging, where you can plan the laminates on the computer itself, and then you can simulate the case and show it to the patient. So diagnostic and treatment planning aids will also include the patient education with the help of photography and demonstration model. So once you scan your patient, and you can get a 3D printed model with the required treatment. Again, tooth preparation for the laminates, it provides the path of insertion. It provides the space for adequate opaquing. So that much amount of tooth preparation should be there. It should provide a definitive seat. It should provide a receptive enamel surface. No preparation should extend anywhere beyond zero point 0.3 to zero point 0.4 mm, 0.4 to zero point 0.5 roughly. Also, a smoother transition between the natural tooth surface and the laminate. The size of the pulp should be small, and patient should be psychologically acceptable to the treatment. So for the tooth preparation, the first and foremost thing you have to consider is the tooth position. So not every tooth can get a laminate. If the crowding is there, ortho is the first line of treatment. If patient is not ready for ortho, then you consider for laminates. While considering the labial embrasure should always be present, because that makes it more aesthetically pleasing. Proximal contact, it was an older concept to break the contact area, but now generally with advent of more newer bonding protocols and the strength of the materials, we generally do not recommend the breaking of the proximal contact area. And why? Because it is an anatomical feature that is difficult to reproduce. Even while doing a composite restoration, or even with the ceramics, it is difficult to reproduce. And it prevents the tooth displacement. If the contact is there, the tooth will not move. If say you have broken the contact, the tooth may migrate towards the center. Right. It also simplifies the time procedures, because you just have to place the laminates over your tooth. It saves the clinical adjustment of the contact areas, which is particularly difficult with the veneers. So it simplifies the bonding and finishing procedures, because you have a particular window to work, and it allows the better access for home care techniques, like you can use your toothbrush and dental floss regularly, like you use it on your natural teeth. For tooth preparation, subcontact area also you have to consider. In diastema closure, you have to prepare a butt joint. So basically, there are four types of preparation. I'll show you ahead. So this is the incisal preparation should be either window, feather, bevel, or incisal overlap. For restoration to last longer, nowadays we recommend incisal overlap preparation for the laminates. So see, the image towards the left of your screen is the incisal preparation. So depending on what extent the laminate is required, you have to prepare accordingly. So older concept was just sorry. The common trend was to preserve the incisal edge in the interest of the tissue conservation. But as in now, the materials have more aesthetically developed. So now the studies recommend that you do preparation that will give an incisal butt joint, and a higher number of fractures were observed. Now, why this was so? Where the free edge is not overlaid, the occlusal third of the laminate veneer is often very, very thin, because you cannot increase the size of the tooth very unnecessarily. So when the teeth are very slender, the difference in the resilience between the prepared tooth and natural tooth and the veneer can, under certain occlusal constraints, lead to the ceramic fracture. So either it should be above your incisal edge, or it should be the incisal butt joint towards your palatal area. So recent concept is the complete coverage of the incisal edge. And why it is recommended? Because it restricts the angle fracture. It enhances the aesthetic properties of the laminate. and veneers, and it allows the latitude for altering the tooth shape also. It changes it facilitates the change in the tooth position. It enables the occlusion to be adjusted. It facilitates handling of and the positioning of the laminate veneer in trine, and particularly during bonding. So you have a particular path of insertion, and it enables the margin to be placed outside the area of the occlusal impact. So where your lower incisor are contacting the upper incisor, you have to make sure that your preparation ends somewhere before it or after the contact, not at the contact area. So these are again some studies why they say that a chamfered preparation is recommended for central incisors, and whereas a window preparation is recommended for the canines. Both the techniques can be used for lateral incisors also. Again, an in vitro studigations where they say why your crack propagates, and the palatal contact of the tooth should remain on the natural structure after the preparation. So you have to either prepare beyond or beyond the finish line, right? So again, another study that was used to evaluate the micro leakage, and they concluded that the window preparation was far way more effective in the terms of prevention of micro leakage at the incisal margins than the overlap type of laminates, right? So to preparation procedure, you have to evaluate the patient, the aesthetic and the functional requirement of the patient, and there are different types of burrs. These are the burrs that can be used. You can even use burrs that have see the label depth grooves and the pilot grooves you can make with this kind of burr. So they come in different sizes: 0.2, 0.3, 0.5. So since the incisor are biplanar, you have to give the depth grooves in two planes. So as you can see in figure on the left of your screen, the below figure. So according to the two planes of the incisors, they have made the depth grooves. So once you have made the depth grooves, you have to make an incisal depth groove, because as we said, we will prepare the incisal edge completely. We have to do the incisal reduction, and then we prepared the tooth with the marking. Then we realize how much amount of preparation has to be done. So for diastemas, the preparation should end at the incisal edge, and for proximal finish line, or for minimal or no color change or and no diastema. So prepared tooth should always be in like a window form with the contact area also prepared. Like if you are doing it for diastema, you have to prepare the contact area also, and take the finish line palatally. So for major color change and no diastema, you can see the figure. So gingival finish line should always be supragingival. You can take it equigingival and put a retraction cord. That's another topic. So increased areas of enamel in the preparation, simplified moisture control, visual confirmation of the marginal fit, margins that can be accessible for finishing and polishing, and access to margin for routine maintenance and dental hygiene procedures, right? So it is better if you keep it supragingival. If the patient has a very low lip line, a very high lip line, and the area is visible while smiling, you can go equigingival or subgingival. So why your gingival line should be chamfer? Because natural tooth, visible tooth profile has to be reproduced, right? Avoidance of over contouring in the cervical zone. So if you prepare a shoulder margin or say knife edge margin, you have to go very near to the margin gingiva. An accurate finish line has to be determined, which should be easy to record, identify, and your lab person should identify that this is the margin where he has to work. So margins of higher fracture resistance and avoid fracture of the edges of the laminate veneer in the course of construction, trine, and final placement. The laminate veneer has to be more easily inserted at trine and during the final placement. So it should be reproducible. When you take the margin subgingival, you have to put the retraction cord, or you have to use any methods for the gingival retraction. And always make sure that you are rounding off the incisal angles. Your lower laminates should not be too sharp and the better angle, because you have to consider the proclination of the patient with upper and the lower incisors. So for premolar, only the label cuts you can prepare, because while smiling, you can see in the figure below, the occlusal margin should be placed away from the occlusal contact and the occlusal grooves. So the overlay should extend to the occlusal 3/4 of the label cusp, and the margins being reproduced with a spherical burr, and they should be connected with the proximal margins with a rounded angle. You can see in the figure below, all the margins are rounded, and you get a window kind of preparation, which can be then bonded. Again, making impressions, your combination of putty light body can be used, or you can use medium viscosity and low viscosity polyvinyl siloxane materials. Provisional restorations, again, it is called as temporization or provisional restoration. And is it necessary? If you ask, so teeth that have been extensively reduced, if say there's more amount of a labial preparation and you have reduced the teeth a lot, so you should basically try and give provisional restorations. Or if you have broken the contacts, then you should give, or the reduced teeth are very anesthetic to the appearance, then you should give the provisional restorations. So you can give provisional restorations of direct composite veneers on an unetched tooth. You do not have to etch your enamel, because if you etch and bond, it will be difficult for you to remove the composite restorations. You can give direct composite veneers, or you can give, even if you say the patient the patient is going out of your town, or you don't want your restorations to fall back, you can spot it and spot bond. Only a single spot of etch, as you can see on the figure on the left. So you can spot etch and spot bond your provisional restorations. Or with say some direct acrylic veneers or composite veneers, using some acrylic matrices, you can give. You can fill up the composite, and you can bond it over to the tooth. So provisional restoration can be given with indirect composite, or you can give acrylic temporaries also. That should be again lab fabricated. Characterization of the laminates, like the shade selection and color selection and characterization, goes hand in hand with the ceramist and the dentist both. Your photographs, your smile of the patient, your existing teeth photographs, all has to be conveyed to the lab. So shade selection is again a very big topic. But the crux of it is the dentist and the ceramist both should be involved while doing the characterization. So with this, we come to an end to the topic of our presentation of laminates.